thank you, Ron, for your very kind introduction. As Ron said, I'm a PhD student based at Trobe University. And for the last 2 years, I've been working on the Defeat Diabetes Research Project, which is where we're looking at the effect of a digital low-carbohydrate diet app on people with type 2 diabetes, and looking at the influence on their glycemic control and other health outcomes. So I've been working on this project with my supervisors, George, who's here today, and Peter, and also together with the help of our GP principal investigators, Liz and Ron, who've been able to provide us with that really important clinical experience of using low-carbohydrate diets in practice. And I'd also like to disclose that part of my research scholarship is funded by Defeat Diabetes. So firstly, I'd like to just provide some background as to type 2 diabetes in the Australian context. And I've pulled this information from the Diabetes Australia website. And it basically just shows the extent of the illness, the disease in terms of illness, mortality, and the overall cost burden to the healthcare system. But what's important to realise is Diabetes Australia actually acknowledge that a large proportion of diabetes, type 2 diabetes, can be prevented or delayed with lifestyle changes. So that presents a huge opportunity for anyone at risk to reduce their risk by making lifestyle changes. But what if you already have type 2 diabetes? Well, in 2021, Diabetes Australia issued a position statement about type 2 diabetes remission, and they indicated that type 2 diabetes remission could be achieved via a low-carbohydrate ketogenic diet. So that was one way that you could achieve it. And what we mean by remission is that the HbA1c, which is a measure of glycemic control over time, is sustained for at least 3 months at a level that's below 6.5%. And that's without the use of any diabetes medication. And we know from research evidence that low-carbohydrate diets are more effective at achieving remission than low-fat diets. And we've also seen in clinical experience with GPs using this approach that people that catch their diabetes early have a higher rate of being able to achieve remission. But it's also important to recognise the role of technology in healthcare. And because we now have access to smartphones and the internet, a lot of apps have been developed to help people manage a range of chronic health conditions, including type 2 diabetes. And my supervisor, George, who's here today, coordinated a large-scale review looking at just that. So he was looking at the effect of digital health tools for type 2 diabetes, and found that people that use smartphones to help them with their type 2 diabetes had better glycemic control than people that didn't. Which brings us to my research now. So we know that there is effectiveness in a low-carbohydrate diet, and we also know that technology can help. So my research is looking at the combination of a low-carb diet app. And what we want to see is we want to measure the clinical outcomes in people with type 2 diabetes over a longer-term period, and see if it impacts on their overall health. And because our intervention is actually a digital intervention, it made sense to do this whole study remotely. And we did this via the help of the Research Data Capture secure web link system at La Trobe University. And because it was remote, we could recruit people from throughout Australia referred to us through their GP. Now, it's really important to mention that GPs were a really important part of our study because as much as possible, we wanted to use data that was already being collected as part of normal type 2 diabetes monitoring and integrate with the current healthcare system. So what we did was we looked at recruiting participants through their GP, and we would give them, once we'd collected some baseline data, we would give them access to the Defeat Diabetes program, which is a smartphone app, and it's also available on the web. And we wanted to check the impact on their glycemic control over a period of about a year but measured at the type 2 diabetes monitoring guidelines, so as given by the RACGP. And as I said before, HbA1c is a diagnostic measure of average blood glucose control. Because we wanted to collect that data from GPs, we thought we would collect some other data as well. And because we wanted to understand the impact on our participants, we also wanted to understand if the intervention was impacting on any of their other health status. So we asked them to complete validated questionnaires at each of those monitoring time points. And importantly, what we wanted to do was understand if their dietary intake had changed over that time in line with the Defeat Diabetes recommendations. So as I said before, GPs were a really big part of our study, and thank you again to our GP principal investigators. We were really heavily reliant on GPs, not just to refer patients, but to measure those clinical outcomes for us and provide us with that health data over time. So you can see that our recruitment actually was a two-phase process. First, we had to get support of GPs that were interested in helping us, and then we could go and get patients to participate in our study. So with Liz and Ron's help, we were able to get the study accredited for CPD with the RACGP. And because of this, we could advertise the study on the RACGP CPD homepage. So that's Continuing Professional Development homepage. We also approached practice-based research networks at university medical schools in order for them to advertise our study to GPs that are interested in participating in research. And finally, one thing I'd like to mention is that one of our supporting GPs, Dr. Avi Charlton, who's here today, she posted the study information on some GP-specific Facebooks for us, and we did get a lot of interest from that. So thank you, Avi. In terms of the education, Liz and Ron were able to provide our supporting GPs with study information and medical guidance, because while some GPs were familiar with low carbohydrate diet management of type 2 diabetes, many that joined our study were not. And it's really important to highlight that some medications do need adjustment on commencement and ongoing throughout when someone implements a low carbohydrate diet. So as you can see, we were quite lucky in that we were able to get 154 GPs supporting our study. And this is great because when we first started talking about this research project, we thought we would be really lucky if we could get 50. And so that was a great result for us. And once a GP had signed a letter of support, and that letter of support was to say that they understood the study requirements and they were happy to refer patients and provide us with the data, I could then send them some patient handouts to help with recruitment. And you can see this is our patient handout that we sent out to GPs. So on the front is some information for the patients that would be referred to the study. So it was our contact details and some information briefly about the study. And on the back, what we had was a list of exclusion and eligibility criteria and a baseline data checklist for our GPs, because we wanted them to be able to take that data down at the initial baseline referral appointment. We tried as much as possible to make the study inclusive, and what we did was we made sure that people had to have a HbA1c of greater than or equal to 6.5% and just be able to use a smartphone or download digital apps or access the internet. However, we did have some safety exclusion criteria as part of our study. We didn't recruit anyone that was taking insulin or that was taking an SGLT2 inhibitor and had a fasting insulin of less than 10. And the reason is that these cases require special management and ongoing monitoring, and it's really beyond the scope of this study to do that. So once a patient had signed consent and provided us with their baseline data, we would grant them access to the Defeat Diabetes program. I think most of you are aware of what this is, but I'll just very briefly summarise. It's a digital app that provides education in the form of lessons, video lessons that outline how to use a low-carb diet to manage type 2 diabetes. And it does provide further resources to help you put it into practice. It does also provide peer support via a Facebook group, and it also provides monthly ongoing webinars where people can learn more, and that gives them that ongoing support while they're going through the program. For anyone that's interested, we also published a study protocol which outlines the details of our study, including how we went about recruitment, any of our data collection methodology, and follow-ups. We also published a systematic literature review because we wanted to understand the current knowledge base of what was out there in terms of specific low-carb digital apps in terms of prevention and management of type 2 diabetes. And I'd like to acknowledge the work of an honours student, Bernice Joost, who did this work, and she identified 6 studies using low-carb diets that found improvements of up to 1.3%. which gave us a good indication of what we would expect to see with our research. So now I'd like to present some of our early results from our 6-month data analysis, starting with our baseline cohort characteristics. So we have more females in our cohort than males, and the average age is around 58. The starting HbA1c is about 7.7%, and you'll note that quite a number of our participants have one or more pre-existing or coexisting medical conditions. And now on to the results. Now I've split this up into the markers that we collect from GPs and also then the health outcomes that we collect directly from participants. Now this is our primary outcome, which is the HbA1c. If I wanted you to remember one thing from this whole presentation today, it would be this. You can see that there's been a 1% drop at 3 months, which has been sustained at 6 months, indicating that there's been an improvement in glycemic control. And you can see this happened in both our male and our female participants. We were also tracking some other health markers that we collected from our GPs. Waist circumference was going down over time, as was BMI, because people were losing weight. We did see significant improvements in systolic blood pressure at 3 months, but for some reason that regressed at 6 months, mostly in our female participants, and we did see improvements in our diastolic blood pressure. In terms of medication use, you can see that some people actually were able to come off their diabetes medications, and a lot of people had their medications reduced. But some people also had their medications increased and some had medications added. But in terms of the clinically meaningful improvements that we are seeing in these participants, what we see is that out of the 91 participants that we have data for at 6 months, 51% have reduced their HbA1c to less than 6.5%, and 13 participants have actually reduced their HbA1c to less than 6.5% and are on no medications for type 2 diabetes. And I'd like to remind you all that before this study commenced, every participant had to have a starting HbA1c of greater than or equal to 6.5% at baseline. So now onto our participant-reported outcomes. As part of our research, we wanted to understand the impact on participants' general health. And to do this objectively, what we wanted to do was we asked them to complete questionnaires at the start and then at each of those monitoring time points. And importantly, we wanted to understand their dietary habits. So we asked them to complete a 3-day food record at the start and also at each of those 3 time points. So I'll start off with our dietary data. As you can see, our carbohydrate intake has dropped when we present this data, it's as a proportion of energy. So carbohydrate as a proportion of energy has dropped at 3 months and been sustained at 6 months. We also see the same thing happening with fat and protein in that they've increased over time and pretty much stayed there. So you can see that it would indicate that people are adhering to the intervention recommendations and they've maintained them over that 6-month period. We ask participants to complete a quality of life questionnaire, which has a visual analog scale, which is that VAS. Now, the way that scale works is 0 is the worst health you can possibly imagine, and 100 is the best health you can possibly imagine. And so we asked that they completed that at baseline and at those time intervals. And you can see there was significant improvement in these quality of life scores. We also asked them to complete a diabetes distress questionnaire. Now, this questionnaire is the short form version of a longer form questionnaire called the Problem Areas in Diabetes questionnaire. Now, distress is actually a distinct from anxiety and depression, and it's primarily associated with how someone feels about their type 2 diabetes. And you can see that over time, those distress scores have fallen, indicating lower levels of distress. We also wanted to assess self-efficacy, so we asked them to complete a perceived diabetes self-management scale questionnaire. Higher scores are associated with higher degrees of self-efficacy, and you can see that they've improved over time. And lastly, a sleep quality questionnaire. So we used a short form version of the Pittsburgh Sleep Quality Index, which is used to assess sleep disorders and sleep quality. And although we didn't find any significant improvements, there was non-significant improvement with lower scores indicating better sleep quality. As part of our program evaluation, we asked participants to ask us how they feel about how they've gone with the program and how they feel about the Defeat Diabetes program and whether they're still using the resources. And you can see at 6 months, many people are still using the resources and they are very satisfied with how their participation in the program. We have identified some emerging themes, both from our program evaluation, but also from the data that we've collected from participants. So as you saw, most participants have major improvements in HbA1c and other health markers. Some have met the type 2 diabetes remission criteria. Many participants report that they feel they're supported by having access to the Defeat Diabetes resources. And our preliminary results provide an estimate of that longer-term durability because most of our results have actually been maintained over that 3 to 6 month period. But we've also identified some barriers. I don't think it will become of any surprise to anyone when I say that life or external stress can be a major factor in influencing any sort of lifestyle change, and including low carbohydrate eating. Some participants note that the food environment isn't helpful, and particularly when they've gone into hospital and they haven't been able to control what they've had to eat. And also what we know is that a lot of GPs just are not aware about using low carb for management of type 2 diabetes. But since this study commenced over 2 years ago now, there has been some progress. I know that there is a medical guideline that was published or co-authored by Dr. Laureen Lawler-Smith, a GP in South Australia. And I also know that there's been the formation of the Australasian Metabolic Health Society, which is focused on providing that low carbohydrate education to healthcare professionals. So I'll leave you with a summary of our results here at this point. We did see improvements in HbA1c, so improved glycemic control. We did see some improvement in systolic blood pressure in our male participants, not so much for our females at 6 months. And across the board, we saw improvements in diastolic blood pressure, weight, waist circumference, and BMI. And in terms of our participant-reported outcomes, we saw non-significant improvements in sleep quality. We saw significant improvements in quality of life scores, distress scores, self-efficacy scores. People were able to maintain adherence to the program, as you saw from their carbohydrate intake being maintained at 3 to 6 months. And our program evaluation shows that people are happy participating in the program and are very satisfied and are continuing to use the resources, which would indicate that they're helpful. They're finding them helpful. And lastly, I'd like to leave you with a case study. So for me as a researcher, it's quite gratifying to see the impact of this intervention on some of our participants. And I'd like to thank Robert for allowing us to share his data with you today. Now, I remember Robert when he first contacted me at the time of enrolment. He did mention that he had a really strong family history of type 2 diabetes, with both his parents and most of his siblings having the disease. But what I remember the most was that Robert seemed to be really frustrated because he found he was following all the guidelines. He was trying to do all the right things, but his diabetes control was worsening and he kept getting prescribed more and more medications. And I think that was his primary aim when he joined the study was, can I do something to reduce these medications? So I'll show you some of Robert's baseline data. What you'll note is Robert's HbA1c on commencement was 8.8, and he was on a couple of diabetes medications, one of which was ceased on commencement of this program. And again, just importantly highlighting the role of GPs in this study to understand that some medications do need deprescription on commencement of a low-carb diet and ongoing throughout. You can see from his 3-day food record, the average amount of carbohydrate that he was consuming was 188 grams. So let's go to Robert's 3-month data where we would follow him up as part of normal type 2 diabetes monitoring. And we collected data from his GP, which showed that his HbA1c had now reduced to 6.8. And he's lost some weight and his waist circumference is down as well. But what you'll note from his food record data is that his level of carbohydrate intake has reduced significantly. So he'd been following the Defeat Diabetes recommendations all that time. So let's fast forward to 6 months where we collect some additional data from Robert's GP. And what you can see is at 6 months, he's reduced his HbA1c to 5.9, indicating improved glycemic control. And one thing I'll also point out is that because we could collect his blood lipids at that time, his triglyceride to HDL ratio, which is often used as a surrogate marker of insulin resistance, had improved to a more favourable level. His blood pressure has also reduced. He's lost some more weight and he's managed to reduce his medications to just 1,000 milligrams of metformin. So I think at that point in time, he'd achieved one of his aims, which was to reduce his medications. And you can see that he's steadily maintained that lower level of carbohydrate intake. I just want to point out something about the food record data. Now, at those times where we take the food records, they're just at the time where we send the questionnaires. But what you'll note is that the total overall energy intake at each of those time points is pretty much the same. So I don't think that Robert I'm not sure, I can't be certain because food record data is the best we can do for each time period, but it is interesting, isn't it? Which brings me to the end of our presentation. So before I finish, I would like to make a special acknowledgement to all the GPs that were part of our study, the diabetes educators, the practice nurses that helped us collect the data, refer patients, and also our participants, because it wouldn't have been possible without their help. So, thank you.